Hi, my name is Bhasin, and I'm the president of Innovation Health Services. Cardiac CT is now a Class 1A test in the ACC chest pain guidelines published in November 2021 due to a demonstrated ability to identify patients who may benefit from invasive catheterization, PCI, and bypass, as well as a novel ability to identify patients who have high-risk plaques that might benefit from plaque regression therapies. The outcomes data in multiple high-quality randomized controlled trials is robust, both in the emergency department and in the outpatient clinic. As an example, the Scott Hart trial, published in the New England Journal in 2018, randomized over 4,000 patients to a cardiac CT versus standard of care stress testing and demonstrated a 40% reduction in myocardial infarction, which was sustained over 5 years after randomization to cardiac CT. Based on multiple trials, the ACC guidelines were updated in 2021 to reflect that cardiac CT is now preferable in those aged less than 65 who are not on optimal preventative medical therapies, which is a lot of patients, favored to rule out obstructive disease and detect non-obstructive coronary artery disease, as well as to evaluate patients with chest pain who might have problems with the aorta or with the pulmonary arteries, which is a lot of patients with chest pain. Yet, high-quality imaging and expert interpretation need to be routinely available for this Class 1 test that is also used, unlike stress testing, to benefit the entire cardiac service line: structural heart, TAVR, electrophysiology, aortic clinics, and adult congenital heart disease evaluations. As a nation, we are facing a general cardiology workforce shortage. MedAxiom data demonstrates over 30% of general cardiologists are now approaching the retirement age of 65 in 2022. Anticipating these trends, we designed and implemented an interstate telecardiology digital practice termed Innovation Health Service. Imaging cardiologists, cardiac radiologists, and systems engineers across North America collaborated to design an extended hours diagnostic imaging service to provide imaging and consultation for multiple time zones, achieving a median ED turnaround time of 38 minutes. How did we do it? We began with empathy for the patients coming in with chest pain in the emergency department, as well as their doctors and nurses. We considered the needs of the cardiac technologists and the cardiac nurses who would be administering beta blockers. Then we considered the simultaneous needs of the imagers scattered around the United States and the orchestrators who would be watching the analytics and dashboards. We recruited cardiac imagers and cardiac radiologists from both coasts, allowing for time zone-based balancing of workloads. And we founded a practice with a culture of service, care for the vulnerable, and co-ownership. Understanding that these were life-threatening cases, we collaborated between radiologists and cardiologists, using instant video conferencing when needed, and scheduled weekly case conferences to raise all our imagers to a level of mastery. Our engineers overcame multiple technologic barriers: the need to transfer complex large data sets to cloud servers with GPUs enabled for 3D visualization software for instant collaborative review, and designed custom smartphone applications to ping specific doctors with specific expertise like acute aortic syndromes or adult congenital heart disease, and to implement the need for browser-based imaging review to increase the portability and flexibility of the work environment, and to maximize the number of providers available at any one time, amongst other solutions. Especially a real-time database for coordination of workflow, including triage by life-threatening priorities, which we named Vivian for Vivian Thomas. Our service commenced in 2019, and we saw rapid adoption. Imaging volumes increased nearly 100% by 2021. We were thrilled to achieve a median emergency department turnaround time of 38 minutes. Patient selection was appropriate. We identified obstructive coronary artery disease in approximately 10% of the patients, and non-obstructive coronary artery disease in nearly 60% of the patients. Only 30% of the patients were normal. During the pandemic, we saw rapid adoption of triple-phase cardiac CT to replace transesophageal echo for pre- and post-left atrial appendage occlusion, as well as prior to cardioversion, to avoid potential staph exposures to COVID. The clinical implication is that guideline-based cardiac CT and cardiac MRI diagnostics including the reduction in myocardial infarction and costs associated with cardiac CT, and the fast emergency department and telemetry bed decompression, can be achieved through the night at health systems, imaging facilities, and freestanding emergency departments despite physician workforce shortages by instantaneously matching idle physician expertise with patients in need. My name is Bhasin, and I'm the President of Innovations Health Services.